Hello everybody. In our series of applied neuroanatomy today we are going to discuss the only gland we have in the base of the skull, the maestro of all the endocrine glands, which is the pituitary gland. Embryology, when you talk about the pituitary gland, we have to discuss the embryology first, and I'll tell you why. Because the pituitary gland has a dual origin. It has origin from two sides. The anterior pituitary, what we call the adenohypophysis, derives from the oral ectoderm, what we call the stomodeum. And the posterior pituitary neurohypophysis derives from the neural ectoderm, as we will see now. So we have the adeno, the glandular tissue, from the oral cavity, from the oral ectoderm, from the stomodeum. The neurohypophysis, the posterior pituitary derives from the neural ectoderm. As you all know, the ectoderm is the source of the neural tissue and the skin. The anterior pituitary actually derives from something called Ruthick's pouch, which develops from the roof of the oral cavity, forming Ruthick's cyst. And the anterior wall of Ruthick's cyst gives rise to the main bulk of the pituitary gland, the glandular tissue, which is the pars distalis and pars tuberalis. However, the posterior wall of the Ruthick's cyst forms the pars intermedia, the intermediate lobe, which is not well developed in human beings. And the posterior pituitary develops from the ventral brain, which descends and becomes adherent to the anterior lobe. So from the base of the third ventricle, it descends and becomes adherent to the anterior lobe. So let's see how development occurs. Imagine that this is the oral cavity, this is a sagittal view, and as we said, the ectoderm gives the neural ectoderm and the oral ectoderm, and by time you start to develop a pouch in the roof of the oral cavity and an infundibulum descending downwards from the neural tissue, from the floor of the third ventricle, from the ventral brain. And gradually, this pouch becomes very well developed, and this part descends downwards, forming the infundibulum. And then, this pouch changes into a cyst, what we call Ruthick's cyst. So this is Ruthick's pouch, this is Ruthick's cyst, and the cyst has got an anterior wall and a space and a posterior wall. And of course, the infundibulum descends downwards, forming the neurohypophysis. So, at maturity, the anterior wall of Ruthick's cyst gives rise to the glandular tissue of the pituitary gland, which is the pars distalis and the pars tuberalis. The pars distalis is in the cella. The pars tuberalis is the part of the pars distalis which surrounds the pituitary stalk. So they are one thing, and the infundibulum descends downwards, forming the neurohypophysis, the pars nervosa, and of course the rudimentary pars intermedia is present in between. If you have persistent cyst inside the Ruthick's pouch, Ruthick's cyst, you will find the Ruthick's cleft cyst, which is a congenital cyst we can see in our clinical practice. How does it come, the Ruthick's cyst? A remnant from the Ruthick's pouch, from the central part of Ruthick's pouch, between the anterior wall and the posterior wall, between what was going to form the pars tuberalis and pars distalis and what is going to form the pars intermedia. That's how you can find Ruthick's cleft cyst here. Another view from the other side, also Ruthick's oral cavity here, the neural tissue here, the encephalon here, third ventricle, the infundibulum going downwards from the median eminence, and what we call the tuber cinereum, then the infundibulum, which is going to form the neurohypophysis, and Ruthick's pouch forms Ruthick's cyst, and the Ruthick's cyst anterior wall form the adenohypophysis, which is formed of the pars tuberalis and pars distalis, and the pars intermedia, which is between the two. Anatomy of the pituitary gland. The pituitary gland, as you all know, is a very small gland. It's actually the pea size of a pea structure in a bony cavity called the sella turcica, and it lies in a midline bony space, what we call the sella turcica, separated laterally from the cavernous sinus by a single layer of endosteum. That's why many of the invasive adenomas leave the pituitary and reach the cavernous sinus, because they are separated by a single layer of endosteum. And the roof of the sella is formed of a dural fold called the diaphragma cellae, as we'll see, with an opening inside the diaphragma cellae called the diaphragmatic hiatus. Why does exist the hiatus? Because it allows a space for the pituitary stalk to pass through. So the pituitary stalk has to pass from the hypothalamus to the pituitary. It has to have an opening in the diaphragma cellae, in the roof of the cella, to go to the neurohypophysis. And of course, the pituitary gland is composed of an anterior lobe and the posterior lobe. And the anterior lobe is composed of two parts. As we said, the pars distalis, which is the main bulk of the pituitary, and the pars tuberalis, which surrounds the lower end of the pituitary stalk. And the intermediate lobe, as we said, is almost rudimentary in humans. It produces melanocyte-stimulating hormone, especially during pregnancy. So the intermediate lobe becomes more evident in pregnant women, and that's why many ladies during pregnancy, they have hyperpigmentation of their skin because of the activity of the intermediate lobe secreting the melanocyte-stimulating hormone, but in normal people it is not apparent. In humans. And this is a view from above. We move the chiasm and we see that this is the sella turcica, and we took it looking from the roof of the sella. This is the diaphragma cellae, and this opening is the diaphragmatic hiatus, and this is the pituitary stalk, and this is the pituitary gland, and you find cavernous sinus on each side of the sella turcica, thin layer of endosteum separating it from the cavernous sinus and the carotid. And very interesting thing here, you see that the PCOM is unrelated, but we have to mention, is very well developed on this side. We have what we call the fetal circulation, 30% of the cases. Posterior circulation sometimes derives its blood from the internal carotid via a big PCOM. You see it here. The other one is of normal size. This is the pituitary gland, this is the anatomy, and I said with this is the anterior pituitary, this is the posterior pituitary, and this is, anterior pituitary is divided, as we said, to pars distalis and the pars tuberalis surrounding the infundibulum or the pituitary stalk, infundibular stalk. And as we said, the infundibular stalk is coming from the hypothalamus, the median eminence, tuber cinereum, and then the infundibulum and infundibular stalk. And we have the pars intermedia, which is not well developed in human beings, and this is formed by the anterior wall of Rathek's cyst. This is formed by the posterior wall of Rathek's cyst, and this is the space Rathek's cleft, where we can have Rathek's cleft cyst. Sometimes we meet in cases of pituitary problems, as we'll see. Another view, hypothalamus, pituitary stalk, posterior pituitary gland, neurohypophysis, adenohypophysis, pars distalis, pars tuberalis, and intermediate lobe. Here another view showing the pituitary stalk from the hypothalamus, from the anterior part of the floor of the third ventricle, and reaching the sella and reaching the pituitary gland. coronal section in the pituitary to know the relations. It is present in the cella, as we said, and the roof of the pituitary gland is the diaphragma cell and the optic chiasm. So above the pituitary gland we have diaphragma cell and optic chiasm, lateral to it single layer of endosteum separating it from the cavernous sinus. Inferior to it we pass in the cavity of the sphenoid sinus. Another view, cadaveric view, coronal view, pituitary gland, optic chiasm, pituitary stalk, cavernous sinus, internal carotid, sphenoid sinus. Again, sphenoid sinus from the floor of the cella, bulging into the sphenoid sinus. Laterally, pituitary gland, single layer of endosteum separating it from the cavernous sinus. Superiorly, diaphragma celli and the optic chiasm. This is an MRI view showing the pituitary stalk in the pituitary gland inside the sella turcica, and this is the optic chiasm. So as you see, the floor is by the sella turcica and sinus sphenoid, and the roof there is the optic chiasm. So this is MRI view showing this is the anterior part of the floor of the third ventricle. This is the pituitary stalk going to the neurohypophysis, the posterior pituitary, and this is the anterior pituitary, and this is the optic chiasm above the cell. Another bony view to show, this is the sella turcica. As we said, the cavernous sinus is on its either side, and the sella turcica has got the dorsum celli, which is the posterior wall of the cella. Each part of the dorsum celli has got a prominence called the posterior clinoid. And anteriorly, there is the tuberculum celli, and each one has got a lateral part called the middle clinoid. And here we have the anterior clinoid. So this is where the pituitary gland lies. Bony cella, posteriorly dorsum celli, lateral part of dorsum celli, posterior clinoid. Anteriorly, anterior wall of the cella, then the tuberculum celli, and then laterally the middle clinoid, and the posterior clinoid is lateral to the optic nerve and to the carotid, as you know from before. We discussed this in detail with the anatomy of the sphenoid sinus. Endoscopic anatomy, as we said, we can have the sphenoid sinus concal, very small. We can have it precellar, and we can have it cellar. Precellar in front of the cella. This is very important for those working transsphenoidal. You can reach the pituitary gland from the anterior wall here, or you drill to reach the floor. This is the commonest type, accounting for about 84-85% of the cases, where you can find reach from the sphenoid sinus well pneumatized, the anterior wall on the floor. Here you reach the anterior wall only, and here you have to drill to reach the cell. You can see it preoperatively by the CT. This is a very nice view I like much, because it is showing you the relation between what we can see from the sphenoid sinus and what we can actually see in real anatomy. So this is an anterior view, and this anterior view, I can see that we remove the anterior wall of the sphenoid sinus, and we have this bulge in the roof of the sphenoid sinus, which is the floor of the cella, and this is the dorsum celli, the site of the dorsum celli, and then we have the clivus, and on either side we have the carotid prominence, and we have the optic nerve going from one side and the other side. So we are looking from the front and above, and then we have the optic chiasm and the pituitary stalk and the anterior cerebral above the optic chiasm. So I'm looking from anterior or anterosuperior. So you can correlate the real anatomy with what we see from the sphenoid sinus. We'll have a separate lecture for the sphenoid sinus, don't worry, but this is the floor of the sella as it appears when you remove the anterior wall of the sphenoid sinus via transsphenoidal approach. This is another view, and you see here, this is the planum sphenoidal. I'm going and removed also the anterior wall of the sinus, and this is the posterior wall and the roof of the sinus. You start from anterior to posterior, the planum sphenoidal, then you have the site for the sulcus, for the tuberculum sulcus, and here we have the medial opticocarotid recess, which is representing the middle clinoid, as we'll see, lateral opticocarotid recess passing into the anterior clinoid. This is the optic nerve, and behind the sella we have the clivus, and on either side of the sella we have the carotid prominence. So when you go transsphenoidally, you see the floor of the sella, you remove the floor, you reach the pituitary gland. What is in front of the floor of the sella is the planum. What is behind the floor of the sella is the clivus. What is on either side of the sella is the carotid prominence. And anteriorly, you have the optic nerve and the opticocarotid recess, or the lateral opticocarotid recess. This is the optic nerve and this is the carotid. So it is opticocarotid recess. But there is also a medial opticocarotid recess we'll discuss later. Another view after removing the clivus and all the posterior wall of the sinus, and you find the internal carotid, pituitary gland, and the clivus. After removed and open the dura, you will see that this is, looking from anterior also, this is the chiasm, optic nerve, right and left optic nerves, the pituitary gland, the floor of the sella. Here, if you remove the clivus, you will find, of course, the vertebral, the basilar, and on either side of the sella, on either side of the pituitary gland, you will find the carotid artery coming from the petrous part, reaching the clival part, and going into the cavernous part lateral to the pituitary gland. Another view, sagittal view, showing the pituitary gland, pituitary stalk. Above it is the chiasm, lateral to it is the carotid in the cell. So this is the right carotid, this is the midline, this is more right, you see the right carotid, and of course this is the sella turcica, and if you go here you have the clivus, and behind the clivus you find the basilar plexus and the basilar artery, and this is the pituitary gland. Blood supply. The blood supply of the pituitary gland is very easy, from superior hypophyseal artery and inferior hypophyseal artery. Superior hypophyseal artery, it arises directly from the carotid. Actually, it is the only medial branch from the carotid. So if you find in the intracranial part the carotid having an aneurysm medial to it, immediately it is superior hypophyseal artery. We talked about it in the anatomy of the carotid, and we are not going to discuss the details now, but it is the superior hypophyseal artery, and it arises from the carotid immediately after it pierces the distal ring, immediately before it goes intracranially, and as we said, it is the only medial branch of the carotid. Inferior hypophyseal artery is a branch from the meningohypophyseal trunk, which is arising from the medial loop of the intracavernous carotid. If you remember, the cavernous sinus, we said that there is, and the carotid, we said that the medial loop is convex posteriorly, and it gives what we call the meningohypophyseal trunk. and the meningohypophyseal trunk, one of the branches is the inferior hypophyseal artery, as we'll see it now, no problem. And this is the most important thing in the blood supply, that the pituitary gland receives the venous drainage from the hypothalamus. When an organ drains the venous drainage into another organ, it is called the portal circulation. And the portal circulation is very important in transferring the factors controlling the pituitary functions. So how does the hypothalamic factors, as we'll see, reach the anterior pituitary? Reach it via the hypothalamo-hypophyseal portal circulation, most important for the hypothalamic control of the pituitary hormones, as we'll see. And the venous drainage of the pituitary gland is via hypophyseal veins into the cavernous sinus. So arteries, superior inferior hypophyseal artery. Venous drainage, portal circulation, receives the veins from the hypothalamus and drains into the cavernous sinus. This is a very nice diagram showing that this is the inferior hypophyseal artery here. This is the superior hypophyseal artery supplying the hypothalamus, supplying the pituitary gland, inferior hypophyseal artery supplying the pituitary gland, and this is the venous drainage of the pituitary stalk, the venous drainage of the hypothalamus. It doesn't drain directly into the cavernous sinus, but it drains into the pituitary gland first, then the cavernous sinus. This is an upward view. Remove the brain, the base, you all know this, and the optic nerve, carotid passing intracranially. Look, immediately after it pierces the distal ring, you find the superior hypophyseal artery supplying the pituitary gland. If you have an aneurysm here, it is from the medial surface of the carotid, it is a superior hypophyseal artery aneurysm under the chiasm. If you go from transsphenoidal view and you go from the planum extended transsphenoidal and you remove a tumor, tuberculum cilium meningioma or craniopharyngioma, then you can see the superior hypophyseal arteries on either side. This is the pituitary stalk, this is the pituitary gland, this is the optic nerve, and this is to show you that the superior hypophyseal artery is a very important artery, not only because it supplies the pituitary gland, but it also supplies the undersurface of the chiasm. And you know that the main supply of the chiasm is from the undersurface. So if you injure this artery during surgery, you can get blindness or get panhypopituitarism, pituitary hypofunction. So this is superior hypophyseal artery from above and superior hypophyseal artery from below. This is a diagram showing, you know, the posterior loop. I'm looking from up. This is the dorsum celli. This is the pituitary gland. This is the carotid. This is medial. And we get from the meningohypophyseal trunk branches, the dorsal meningeal artery, the tentorial artery of Bernasconi and Cassinari, and we have the inferior hypophyseal, which is not apparent here, but here it is apparent again. The medial loop, convex posteriorly. This is the dorsum celli. This is the dorsal meningeal artery. This is the meningeal artery of Bernasconi and Cassinari, meningohypophyseal trunk. And this is the inferior hypophyseal artery. So from where arises the inferior hypophyseal artery? From the meningohypophyseal trunk. From the medial loop of the internal carotid artery inside the cavernous sinus, which is convex posteriorly. It is part of a trunk which gives rise to the inferior hypophyseal artery, dorsal meningeal artery, and tentorial artery of Bernasconi and Cassinari, supplying the tent. Again, blood supply, superior hypophyseal artery from the carotid, inferior hypophyseal artery from the meningohypophyseal trunk, supplying the pituitary gland, supplying the hypothalamus, and the venous drainage of the hypothalamus, portal circulation to the pituitary gland itself, mainly the anterior pituitary, the adenohypophysis, and then it drains its venous blood into the cavernous sinuses through the hypophyseal veins. One more time, inferior hypophyseal artery, superior hypophyseal artery, supplying the hypothalamus, infundibulum, and the pituitary, portal circulation from the hypothalamus, carrying all the factors controlling the pituitary hormones. That's why before it doesn't drain, the hypothalamus doesn't drain the veins into direct sinuses, but it drains it first to the pituitary. All the control of the hypothalamus on the hormonal function is through this portal circulation. Very important. Hormonal control and function of the pituitary gland, as we said, anterior pituitary is under the control, all the hormones are under the control of the hypothalamic releasing factors, which pass in the portal circulation, as we said. But the posterior pituitary is actually its reservoir. But the hormones are secreted directly from the hypothalamus, actually from the magnocellular part of the hypothalamus, which we call the supraoptic and paraventricular nuclei, which is secreting the antidiuretic hormone vasopressin and the oxytocin, and they are stored in the neurohypophysis. So the anterior hormone of the pituitary are secreted from the pituitary itself under control of the hypothalamic releasing factors, but the posterior pituitary are stored in the neurohypophysis and are secreted from the hypothalamus, supraoptic and paraventricular nuclei, and they are the oxytocin and vasopressin. Okay? So the hypothalamus, to remember, I'm not going to discuss details, you know all about it in the anatomy of the hypothalamus, but you should know that the growth factor, the releasing factors pass into the anterior pituitary via the portal circulation, and that the supraoptic here and the paraventricular nuclei, they secrete and they store in the neurohypophysis. So these are the hormones secreted by the pituitary and their control. The somatotropes is secreted from the hypothalamus to control the human growth hormone. And the cells constitute 30 to 50% of the pituitary are growth hormone secreting cells. And the corticotropes, we can call them corticotropes or the cortisone releasing factor. So corticotropes from the hypothalamus controlling the adrenocorticotropin or the ACTH, adrenocorticotropic hormone, 20% of the cells, and the thyrotropes from the hypothalamus controlling thyroid stimulating hormone TSH, 3 to 5%, and the gonadotropes from the hypothalamus controlling the gonadotropic hormones, which are the luteinizing hormone and follicular stimulating hormone, 3 to 5%, and the lactotropes from the hypothalamus controlling prolactin secretion from the pituitary, and the cells represent from 3 to 5%. So these are the pituitary hormones, and these are the factors, hypothalamic factors, controlling the pituitary hormones, and these factors reach these hormones to control them via the portal circulation from the hypothalamus to the pituitary. Again, neurohypophysis, supraoptic paraventricular nuclei, oxytocin, vasopressin, secreted inside the hypothalamus and stored in the neurohypophysis. The rest of the hormones, the releasing factors, the gonadotropes, the corticotropes, the thyrotropes, and so on, gonadotropes, secreted from the hypothalamus, reaching the pituitary gland, anterior pituitary, via the portal circulation, and then the pituitary drains through the hypophyseal veins. So, inferior hypophyseal artery, superior hypophyseal artery, supply, portal circulation, venous drainage of the pituitary into the hypophyseal veins. This is to show you, to remind you of the functions of the pituitary gland. And we have the anterior pituitary and the posterior pituitary. Anterior pituitary secretes the thyroid stimulating hormone controlling the thyroid function, the adrenocorticotropic hormone ACTH controlling the adrenals, and follicular stimulating hormone LH controlling the and follicular stimulating hormone and luteinizing hormone in females controlling ovulation and the secretion from the corpus luteum of estrogen, progesterone, and in males controlling the interstitial cells of Leydig cells in the testis for the spermatogenesis and for the erectile function. Also, it secretes the growth hormone controlling the growth of the body, and it secretes the prolactin, which is controlling the milk secretion from the breast in females. And this is the anterior pituitary. Posterior pituitary, antidiuretic hormone working on the distal convoluted tubules for the facultative water reabsorption, controlling the fluid balance inside the body. And oxytocin. Oxytocin is important uterine contractions during delivery and during orgasm, and contraction of the myoepithelial cells of the basket cells surrounding the acini of the breast to expel the milk. They are stimulated by sucking of the nipple, oxytocin, contraction of the myoepithelial cells like muscles, contracting, expelling the milk from the breast. So, and all these are under control of the releasing hormones of the hypothalamus, and the releasing hormones reach the anterior pituitary via portal circulation, and the posterior hormones are secreted from the hypothalamus supraoptic paraventricular nuclei and stored in the neurohypophysis. Clinical applications, empty sella. We see it so many times in practice. Empty sella could be a normal finding. Don't panic if you have an empty cell. Actually, it is not empty. There is the pituitary is here, but it is compressed by a very wide arachnoid pouch passing through the diaphragmatic hiatus, compressing the pituitary gland. So it is called the primary empty sella. You can find it with benign intracranial hypertension. You can find it in obese people, and you can find it as a normal finding. So finding an empty sella is not necessarily a problem. Sometimes it can cause some pituitary hypofunction, and sometimes, very rarely, can cause the chiasm to go down. So you elevate it from transsphenoidal surgery called the chiasmapexy. You fix it, you put fat to elevate the chiasm. This is the empty sella, pituitary stalk, and the pituitary gland. It's not empty sella actually. There is, of course, secondary empty sella after surgery or after radiotherapy, and this is what we call the primary empty cell. Pituitary adenomas, common, 10% of the brain tumors. They are mostly benign. They can be micro or macro adenoma. They can be secreting or non-secreting. The secreting adenomas can secrete, as you know, ACTH secreting Cushing, or growth hormone secreting acromegaly and gigantism, or they can be secreting prolactin, hyperprolactinemia, or non-secreting, either silent, non-secreting, or null. Silent is non-secreting adenoma, but having the hormones inside the cell. Null cell adenoma, they have no hormones inside the cell. So the non-secreting can be divided into silent and null. We'll talk about it when we go to the pituitary adenomas in some other time, but you have to know that the pituitary adenomas are micro inside the pituitary or macro outside, can be secreting, non-secreting, and they can produce visual symptoms compressing the chiasm, as we said, is on the upper surface of the pituitary gland, or hormonal symptoms according to type of cells involved, or both, hormonal and visual. There is something called pituitary apoplexy. It's present in 10% of the macroadenomas. What is apoplexy? It is an acute event. Could be hemorrhage, could be infarction, and in these cases you get sudden severe headache, sudden severe deterioration of vision, and you do the CT or you do the MRI, you find blood or infarction in a macroadenoma which was not discovered before. So there is something called pituitary apoplexy, and there is something called incidentally discovered microadenomas present in 0.16% of the normal population of the whole world, and we call it incidentaloma. What is incidentaloma? Incidentally discovered microadenoma which is not secreting. Of course, if it is secreting, it will be symptomatizing. But if you do an MRI for whatever reason and you find a small adenoma, a microadenoma in a patient that never complained, leave it alone. Most of them stay stationary and just observation. Invasive pituitary adenomas are benign tumors, but they invade the dura, the bone, and the sphenoid sinus. So the microadenoma here, we have a coronal cut of MRI, and you see an area of hypodensity. On the right side, this is a microadenoma. This is the pituitary gland. Incidentaloma, it is also a microadenoma, but the first one was secreting, but the second one was not secreting and discovered accidentally, so you leave it alone. The first one you operate, the second one you leave it alone. And the macroadenoma, the pituitary gland, can give a very big adenoma that can reach the cavernous sinus, not invading here, and it can reach upward. You see it is stretching the optic chiasm. This is a macroadenoma filling the sella, causing widening of the sella turcica, rarefaction of the dorsum sellae, elevation of the optic chiasm, and reaching the carotids in the both cavernous sinuses, displacing them laterally. Invasive adenoma, you can have huge adenomas. By the way, invasive adenoma is present in 33% of the cases. Invasive doesn't mean should be a big adenoma, giant adenoma. Some invasive adenomas were found to be microadenomas on the surface of the pituitary, and they are found to invade the pituitary gland. So invasion is a behavior. When you do of this huge tumor, this invasive tumor that invaded the dura, the bone, and the sinus, if you do a microscopic pathological verification, you'll find it benign. But you will find certain factors, what we call the Ki67, very high. In this Ki67, you see the incidence of the invasive cells inside the adenoma or the meningioma. If it is more than 3 to 5%, it is an invasive tumor. Look here, it destroyed the sella, it reached the sphenoid sinus, destroyed the medial wall of the cavernous sinus, and filled the cavernous sinus bilaterally. Another case, invasive giant adenoma, what we call the giant adenomas above 5 centimeters in diameter, called giant adenomas, extending and reaching heroic space and heroic extension, heroic size. Invasive adenoma. Ki67 is high, but still looking benign. Thank you very much for your attention, and we hope we meet very soon with the anatomy of the sphenoid sinus. Take care.